All right, it gives me great pleasure to introduce our next speaker, Dr. Nali. She's an assistant professor at the Cummings School of Medicine in Department of Health Information. Oh, there you are, sorry. She's here to talk to us today about strategies that we might be able to use to recognize sepsis in the recognize sepsis using electronic medical records. And I'll just remind everybody about their time limits so that we can have some time for discussion and questions as well. Thank you.
Hello, everyone. My name is Nali. I am an assistant professor in biostatistics and health data science at the University of Calgary. I also have a adjunct position in the Department of Computing and Software at McMaster University and the McMaster Center for Transfusion Research. Thank you very much for having me here to discuss the strategies to recognize sepsis using electronic medical records. So the talk will be mainly on data science. So I hope I won't throw you off. So the key question I would like to discuss in this presentation is, what are the strategies to recognize sepsis using EMRs? I will start with an overview of the health data sets in Canada, including EMR data. Then we will look at the current detection methods using EMRs for sepsis detection. And then we will wrap up by the discussion of benefits and limitations of machine learning for sepsis detection using EMRs. So this table, I'm going to show you an overview of the health data sets we have in Canada, starting with administrative data. So we have hospital discharge information, including demographics, diagnosis, procedures in the discharge abstract data, as Dr. Garland just mentioned earlier. And we also have emergency dynamics data from NACRS data, and comprehensive detailed information about health services, insurance, billing in the claims data. In our EMRs, we have structured data for both inpatients and outpatients. So structured data may include like medications, laboratory tests, vital signs, and intensive care data. These data can be longitudinal and all structured based on different data formats. And we also have comprehensive unstructured data for both inpatients and outpatients. So unstructured data could include free text, physician notes, and also imaging data. And we also have many clinical registry data. Here I just put two examples, the Approach database in Alberta and the Canadian Cancer Registry data. So we can see from this table, we have lots of different data sources and different data types. So if we can combine all these diverse data sets and like connect it together, then we can facilitate a comprehensive analysis, modeling, and tool development for clinical support. And the multivariate nature of EMRs can provide lots of information for sepsis detection. For example, if we can combine different data tables like vital signs, laboratory tests, medications, and patient histories, we can imagine that we can create the longitudinal and comprehensive patient profile for each patient. That might be helpful for sepsis detection. However, there are a lot of challenges. First, and the most important one, regarding to the data types in EMRs, we have a lot of different types of variables. We also have very comprehensive data in EMR. So that means it requires tailored modeling approach in order to use the vast amount of data efficiently. However, determining such optimal modeling strategy is challenging. It's not clear. And furthermore, conditions like sepsis may present high heterogeneity. Based on its origin and patient underlying condition, sepsis can present in different ways. So there is a need for advanced and specialized modeling approach to handle this large volume of data and the disease heterogeneity efficiently. So how EMRs have been used in the current literature for sepsis detection. So we conducted a narrative review for analytical assessment through a PubMed search on August 21st, 2023. We found the methods can be divided into two categories: supervised learning for sepsis prediction and unsupervised learning for sepsis subphenotyping or subgroups. So before I dive into these publications, I want to give a brief introduction of these two algorithms, supervised learning and unsupervised learning. Supervised learning or prediction models commonly used machine learning models these days in the medical literature. So the purpose of supervised learning is to discover the relationship between the input variables and the labeled outcomes in the training process. So that means this algorithm produces a function that maps the input predictors and the labeled outcomes, and then use this trained relationship to predict future outcome. So that means essentially supervised learning is used when there are labeled outcome data in the training process. On the other hand, unsupervised learning is used to train a model without labeled data in the training process. So it's often used to discover hidden relationships and patterns within the data. And it can group similar data points into a specific number of groups. And then we can use the analysis for the next step. So it's usually used in the early stage of the study to better understand the data you have and data structures, especially the hidden relationship between data elements. So to summarize, supervised learning is to map inputs to known outputs. And unsupervised learning is used to find relationships, to find patterns using the data itself. And compared to supervised learning, unsupervised learning can handle much larger data volume as it doesn't require labeled data. But also that's a drawback because there is no labeled outcome. It's very hard to compare different unsupervised learning models because there is no gold standard performance. But as for the future of AI, both supervised and unsupervised learning have their roles. However, now unsupervised learning is gaining a lot of traction because its potential to investigate a large amount of unlabeled data. So now go back to the search of the literature. We found 5 systematic review papers on using supervised learning for sepsis prediction. And these 5 systematic review papers covered a total of 79 unique publications on sepsis prediction. 53 of them were on prediction models for sepsis diagnosis, and 26 of them were on other outcomes like mortality and length of stay among patients with sepsis. And all these studies used the EMR data. Some used the MIMIC-3 clinical database that is freely available to researchers, and some used the hospital EMRs. 4 systematic reviews with 70 publications consider structured EMRs, including medications, laboratory tests, and vital signs. And 1 systematic review with 9 publications discussed different natural language processing model over unstructured clinical notes in EMRs. So, as we know, these are all supervised learning for prediction models. As we mentioned earlier, they all require labeled outcomes to train the model in order to find the relationship between the input variable and the labeled outcomes. However, across these papers, you can see there is a wide range of reference standards used for sepsis when developing these prediction models. Here, I just list the definitions found in the papers. You can see clearly there is a high variation of defining sepsis in these prediction models. In that case, how we can compare these models? It is very challenging to make a reasonable comparison between these methods, and evaluating their suitability in other settings is also challenging. So in summary, based on what we found from the systematic review papers, we summarize in three concerns. The first one is the high risk of bias and heterogeneity. This is mainly caused by the different sepsis definitions for outcome labeling in the prediction models. It also caused by the varied data sources, data pre-processing techniques before developing these models, and the modeling approach and the training process, as well as the variations in the evaluation metrics when comparing the performance of these models. The second concern is the model validation. So some studies showed effectiveness in specific patient groups or specific data sets. However, the generalizability remains a concern and is unclear. And most of these studies actually focusing on intensive care data, which needs a broader application and validation for other more general hospitalized patient cohorts. And the third one is the appropriate integration of these machine learning models into health systems is challenging. Although these models can generate alerts, but turning these alerts into early intervention is not straightforward. And too many sensitive alerts can cause alert fatigue and also increase the resource demand, which is exactly the opposite when we're creating these models, because we want to reduce resource and we want to improve the diagnosis accuracy. But it may not turn out that way. And also, patient outcomes can be affected by many factors that could be beyond the scope of these prediction models, so they may not lead to better patient outcomes. And for the second category, we found 6 publications considering unsupervised learning for patient segmentation without the need of label data using EMRs. And 3 papers were on sepsis clustering for patients in hospital settings, and 3 remaining papers are on the exploration for sepsis subgroups or subphenotyping among patients with sepsis. So among these 6 studies, 5 of them considered only less than 15 variables in the large amount of EMRs for their modeling approach. The commonly used variables include vital signs, SOFA subscores, age, sex, and a few laboratory test variables. There is only one study actually used a comprehensive EMR data, including many elements from medications and laboratory tests and also comorbidities. But that study is mainly for sepsis treatment pattern subgroups among patients with sepsis. So it's not exactly for sepsis detection. And 2 of these 6 studies are particularly interesting because they use the unsupervised learning approach for sepsis detection. They did use a small number of variables only, but this modeling approach could scale up to a large amount of EMR data. So the first one is Mayhew et al. Used a probability-based clustering algorithm over a large number of hospitalized patients. They did a very nice job to describe the methodology. However, the main limitation of this study is that it lacks a separate validation analysis. Although they identify different patient clusters, but it's hard to know which cluster actually related to sepsis. So because there is no separate validation analysis. The second paper, Zhang et al. Used a semi-supervised learning approach. This means that they combine supervised learning and unsupervised learning. So they start with an unsupervised clustering algorithm to separate the patients into 3 or 4 groups using a few EMR variables. And then they use the cluster labels as the predictors to train a logistic regression model to predict sepsis diagnosis. So in this way, they can learn the association between the sepsis cluster labels and the sepsis diagnosis. So that's more like an improvement of the model interpretation and validation purpose. However, this study has a significant limitation because they consider a cross-sectional design which may have high risk of recruitment bias. Okay, just to summarize, across these 6 publications, we found that these papers shows the potential that using unsupervised learning could identify distinct clusters of sepsis subgroups using EMR data. And they also present significant association between clusters and the key clinical outcomes like mortality, and also reflected the high heterogeneity in sepsis patients and sepsis treatment patterns. However, the limitations include the lack of separate validation analysis, data handling challenges, limited inclusion of key clinical variables, and the lack of exploration of the impacts of longitudinal interventions and care process. And furthermore, the complex computational requirements and the discrepancies between data-driven results and biological outcomes can increase the challenges for model, for model interpretation and model implementation. And also, the last one, generalizability is always a concern for this type of modeling approach. Although I mentioned so many challenges and limitations of these algorithms, there could be a lot of potential and benefits for unsupervised learning. So the first one and the most important one is label independence. Unsupervised learning doesn't require the labor-intensive manual labeling process to create this type of data set for training the model. And it can also identify hidden indicators and risk factors. So for example, by separating the patients into different groups, it might have the opportunity to identify the variant risk of sepsis in those clusters. And it can handle the large amount of EMR more efficiently. It can also be used to enhance the supervised learning approach, just like the paper I showed earlier, the Zhang et al. Used the combination between supervised and unsupervised learning to improve the detection of sepsis. And this algorithm can be adaptable to the evolving EMR data with new patients. So if we can leverage all these benefits while addressing the challenges of these algorithms, there could be a potential to enhance more like an automated detection system for sepsis using a large amount of EMR data. Just to summarize, I hope I didn't throw you away. For this presentation, I will just read it aloud for this takeaway message. I believe using EMRs for sepsis detection may require a combination of supervised and unsupervised machine learning methods with a focus on comprehensive data integration, collaborative model training, expert insights, and continuous model evaluation to address challenges of data volume and variation, as well as sepsis heterogeneity. That's all for this talk, and I would like to thank my team member for Team 1 under the Unsupervised Learning for Sepsis Detection. I appreciate the funding we received from Sepsis Canada, Alberta Innovates, and CIHR. And thank you for your attention.
One question? No, thank you very much. Certainly, yours and Alan's talk highlight some of the struggles for those of us who've been looking retrospectively. As you start to build your platforms, how are you focusing on particularly patients coming in through the emergency department, or are you looking at hospital-acquired infections and sepsis as well? Because I think they're two different things. Mm-hmm. And I think where many of our gaps still occur, yes, hospital-acquired sepsis is, or hospital-acquired infections and leading to sepsis is a huge problem, has heavy economic burden that Callie's going to talk about next. But our challenge is that emerge recognition at triage through to bedding appropriate management, and that's the 80% 90% of the problem. So I just challenge you as you go in. I totally see the value of both, and we know that, you know, you've got Epic in Alberta, we've got Epic here in Hamilton, there's some Epic in Toronto now and in Ottawa, that their supervised method, A, is based on old definitions, B, uses early warning scores that are old, and isn't widely shared, and has been criticized in the literature in terms of its capacity to actually trigger people to say this is sepsis. So it still requires that clinical input. So I would challenge you as you start to sort of build this unsupervised portion of that and use the natural language processing and everything else, that you think about the fact that Emerge is probably our first focus point, and it's going to come out tomorrow more about thinking in the emergency department as opposed to the hospital and the ICU, but we really need to think about that piece of it. So congratulations on setting the tone for the work, and we'll look forward to hearing where this is going.
Thank you very much for the feedback and the comment. Thank you.